Good afternoon, and thank you all for joining the Kentucky Primary Care Opioid Stewardship Program webinar today. I'm Dr. Marilyn Connors, and I'm the physician consultant for the Primary Care KYSOS team. I'm joined by my colleague, Shanna Jaggers, who is our outpatient primary care pharmacy consultant, and together we comprise the outpatient primary care team. We work with hospital-owned primary care clinics to implement safer and more consistent opioid management of patients with chronic pain who are on long-term opioid therapy. Before I introduce my speaker today, I'd like to take a few minutes to review some housekeeping items. For attendance purposes, please type your name, profession, or title, hospital or clinic that you are affiliated with in the chat box. We ask that you mute your lines throughout the presentation and hold your questions until the end. At the end of the presentation, you can ask questions by unmuting your line or typing your questions in the chat box, whichever you're more comfortable with. We will monitor the chat box at the end of the presentation. This webinar is being recorded, and it will be posted to the KYSOS website under the section entitled Recordings. Our website can be found at www.kentuckysos.com. Just remember to spell out the full name of Kentucky to access the website. Slides will be made available at the end of this program. And the title of our presentation today is The Intersection of Opioid Use Disorder Amongst Women Who Experience Sexual Violence. Our presenter today is Serenda LoBue, and she is a criminologist with over 13 years of experience in research, direct services, and providing training and technical assistance on the topic of interpersonal violence. Serenda, I will turn it over to you.
All right, thank you so much, Marilyn. And again, thank you all for being here today and allowing me to come in and talk about this topic that is very important to me. And as Marilyn had said, since we're going to save questions to the end, I did go ahead and minimize my dialogue box there. So if for any reason we were need to have a stop point, just please, Marilyn, unmute and let me know. So welcome. As she said, my name is Serenda LoBue, she, her pronouns, and I am the collaboration specialist at KSAP, the Kentucky Association of Sexual Assault Programs. And so today we're going to be discussing the intersection of opioid use disorder among women who have experienced sexual violence. So really that's going to be talking about anyone who has experienced or has a history or victimization of sexual violence. We're going to be going over an introduction to who KSAP is, what sexual violence kind of looks like in Kentucky, what we do know, what reports do say, and what we do hear from patients and survivors. Some overall health implications about sexual violence that then leads us to the intersection of the opioid use disorder. And then when you all are working with folks and you have patients that come in, what does it kind of look like when sexual violence is disclosed and some best practices? And then finally, we'll wrap up with some resources and referrals that are specific to Kentucky before we head into our Q&A. So to begin, KSAP, in case you're not familiar, we are the coalition of the 13 sexual assault resource centers throughout the state of Kentucky. So in Kentucky, it doesn't matter which county you are in of the 120, your county lies within an area development district, and those area development districts are all served by a sexual violence resource center, also known as rape crisis centers. And our mission with our 13 programs is to speak with a unified voice against sexualization, so that we kind of always have an idea what is going on with sexual violence across the state, as well as what barriers and what resources can also exist. And then here you are seeing a map of our service areas. So here are the 13 programs. So for example, I currently reside in Barron County, And so I can go here to Barron County and I can see that my local rape crisis center is Hope Harbor. They are based out of Bowling Green. And you will see the main offices for all of our programs, but they also have satellite offices as well. And so in the smaller counties, some of the more rural areas, they may have satellite offices located there. And the core services that you can obtain at any of the 13 programs across the state are universal. So there is a 24/7 crisis line and support line. And oftentimes when we hear that language, we think it's just for folks that are directly affected, so just victims or patients that have experienced sexual violence. But it's really for anyone who is needing to seek immediate help or immediate support and answers for topics revolving around sexual violence. Those are lined and maintained by folks here in Kentucky, staff and volunteers of the 13 programs. They provide crisis intervention and crisis counseling services, advocacy, including accompaniment for sexual assault forensic evidence exams. So if you are familiar with ED work and you have worked in an ED or you do, then you might be familiar with a sexual violence resource center advocate that comes in 24/7, 365 days a year to provide that support throughout a sexual assault forensic evidence exam, or really just when someone discloses to the emergency department that they've experienced sexual violence. They also provide mental health and related support, including therapy, information about maybe what does the criminal justice process look like, what are some resources for trafficking survivors, just all types of information around sexual violence in their community, and also referrals. Maybe the Rape Crisis Center is not the most fit agency at that time to assist a patient or survivor that's affected. So they often are going to refer them to community service providers that they feel could be beneficial. And then 24/7 consultation. So whether that's with other professionals, community members, other advocacy groups who all want to work to support survivors. And then what we're doing here today, it's public education and professional training. They also, our local programs will also provide that for their communities. So maybe you oversee a local clinic. So I have TJ Urgent Care here in my area. I also have a med center urgent clinic now. So multiple healthcare systems in my community. And so those local rape crisis centers can come in to provide information, resources, training, just that consultation for your local offices and departments. And we can't get too far into the discussion today, right, without talking about what is sexual violence. And if we had a little bit more time, we might kind of go into, hey, what does that look like for you? Because we do know that sexual violence and what that word means, sexual violence, may be different depending on who you ask or different depending on their experience with it. But we all agree that it's unwanted, non-consensual sexual contact of any kind. So that can be physical, it can be verbal, or what we're also seeing a high rate of is it's virtual, it's with imaging, or threats of it. So standard definitions and Kentucky law include things like rape, molestation, fondling, penetration, stalking, coercion, threats, and more. There's a lot of types of interpersonal violence. And then again, what legally is defined as sexual violence in Kentucky, we know that there are laws that say, however, if a survivor is being sexually harassed, and that is affecting their day-to-day living, it's affecting their mental health and well-being, it's not for us to say, oh, well, it's not even against the law what's happening to you, so it's not as serious, or there's not much that I can do about it. And that's really the kind of the unified voice that we're speaking of through KSAP and our programs. If anyone's been affected by this issue, we want to be able to offer support and assistance. And sexual violence is a public health issue. It is, recognized as a public health issue, and we want it to be treated as a public health issue by the healthcare system. So the same as other types of issues that we see, like the opioid epidemic going on in our state, we want to see folks recognizing, discussing, treating, and caring for patients that have a history of sexual violence just the same as we do. For example, the American Diabetes Association has a phenomenal community engagement campaign and community awareness campaign that they use. We want sexual violence to be as embedded in our healthcare system as those other types of awareness campaigns and issues. And then Kentucky mandatory reporting laws do apply to you, to me. Everyone in this state is a mandatory reporter. We're not going to dive into those specifics today. If you do have a question specific to mandatory reporting, please save it to the end, or you'll also get my email and you can always follow up if maybe you're watching the recording. And then what we do know about sexual assault in Kentucky, or at least what's reported, is 40% of women in Kentucky will experience contact sexual violence in their lifetime. So that does mean physical. So physical sexual violence in their lifetimes. And then I know this is directed towards women, of course, in Kentucky, but we'd be remiss not to mention that it also affects nearly 20% of men in our state as well. And again, these are self-reported numbers. We know that sexual assault is underreported in all areas. We know it's difficult for folks to self-disclose. Nearly a quarter of Kentucky women will experience completed or attempted rape in their lifetimes. And then of the folks that are, or of the females that are affected by that, half, almost half, were first raped before the age of 18. And many of you may know that Kentucky has, one of the highest rates, if not still the highest in the nation, of substantiated child abuse. Sexual abuse is very prevalent among children in our state, and I often say that children grow up. And while we work very diligently to serve children when they're interacting with the different systems and with healthcare, I feel that we do often forget that the 6-year-old, may become the 16-year-old, and then the 36-year-old who has difficulty accepting and coping with the trauma throughout that lifespan and health ailments that arise from that. And so do we kind of look at pediatric patients as a patient across the lifespan and knowing kind of how they've been affected by that trauma? And we see direct, short-term, and long-term health implications from sexual violence the same way as we do other types of health ailments. So a lot of these are either directly following an assault, so they're getting a sexual assault forensic exam, or it's within that 6-month window of following up after a sexual assault forensic exam has been provided to the patient. 1 in 7 reported female victims contracting an STI. And again, this is immediately following the assault. 1 in 3 were injured. So that was an injury outside of an injury just sustained from the sexual assault. And then 2 in 3 were concerned for their safety. 2 in 3 were fearful. And then 1 in 7 became pregnant. So as healthcare providers, you all are aware, these are, common concerns, that you all have when patients present to you immediately following sexual assault. And we also see high rates of these same things for men. But then the negative mental health outcomes that we see developing from the trauma that occurs from sexual violence. Looking at teenage girls, 80% suffer serious mental illness. And oftentimes, when that's categorized as serious mental illness, it's not short term. The ability to, as especially a teen or the younger you are, to develop coping skills, to kind of reach out for support, to even know what's available, we know is much lower than it is for adults and folks with fully developed brains. So the long-term implications from that can be substantial. And then short and long-term conditions such as avoidance, depression, and PTSD. And then, as you know, we know chronic health conditions and disorders can develop. So diabetes, high blood pressure, IBS, panic disorder, chronic migraines, insomnia. That describes not just so many people in my age group, but that type of health history. We see it so often in Kentucky. And we may think it has to do with more with, maybe stress, lifestyle choices, diet, and things like that. However, how many of these folks have experienced a history of victimization, and therefore these have become chronic health conditions primarily because of that state, that unhealed state of kind of trauma and long-term crises that their body stays in. And then what we're going to also talk about, of course, today is we see health implications such as risky health behavior, so substance use and use. And we see that as one of the health implications of women who have been affected by sexual violence. That is both a short-term and a long-term implication that patients report. And then harmful coping mechanisms overall can develop. Again, looking at maybe you're not an individual that copes well with things. Maybe you were not taught healthy coping skills or healthy coping mechanisms. And so substance use and abuse, self-harm, we can see those things all occur with that history of sexual violence. And the big piece of why we're here today is, how does sexual violence and substance use really intersect? How can we look at what's going on with women in our state and opioid use and misuse? And where can we, along the road, kind of stop and see where sexual violence affected them? And that number one, first and foremost answer is always trauma. And I'm using trauma in the definition of an adverse experience that has happened to someone that is mentally, emotionally, psychologically, and at times, physically difficult for them. And it inhibits their day-to-day well-being and their ability to kind of fully present. And people who report using substances most often report having experienced trauma. And there's an asterisk there because, again, how we're asking folks about what trauma they've experienced can also depend on the answer that we're going to get. We may identify something as trauma, but another individual may identify it as just a core piece of their childhood, or it's just something that happened to them and they don't really internalize it as a traumatic experience. And it's not for us to tell them what to feel, but it's for them to understand the implications that can come from that trauma. And so in our local programs, the sexual violence resource advocates are trained specifically on trauma-informed care practices. So that's talking to someone that has had an adverse experience and supporting them and asking questions in a way that are not meant to re-trigger them, that are not meant to sound as you're accusing them of anything, but really in a neutral way that help them know that you support them and that you're able to offer support. They will also train on primary prevention strategies, because at KSAP, at our member programs within the sexual violence movement in Kentucky, we really think that if we prevent this from day one, we're not going to see folks using substances to cope with their trauma. If they never experience that trauma, then they're never going to have to heal from it. And so we really do believe stopping folks from falling in the river, so to speak, which is a common example, is the best way to guarantee that they're going to be able to be their happiest and their healthiest. Because we know sexual violence doesn't happen in a vacuum, and victims have often experienced compounded trauma. So that is trauma maybe as a child, maybe that was neglect or physical abuse. And then later in life or early adulthood, that could be physical sexual assault. And that can either happen again later in life or make them more susceptible to developing those long-term chronic health issues and negative coping skills. We also know the individuals that cause harm report to have experienced compounded trauma. So it's not just folks that have been victimized, it's also folks that cause harm, which tells us a lot of folks are impacted by trauma. And ACEs, as you are probably familiar, adverse childhood experiences, that is a score that goes to 10, and it looks at what trauma happened in childhood. And then with the movement in sexual violence, our practice looks at trauma across the lifespan. So, meaning we want our sexual violence resources to be there for anyone, whether they disclose as a 6-year-old or whether they're coming forward as a 60-year-old, because we all have women in our life that we care about. And whether they've been directly affected or not, we all know someone who has. And in the last 10 years that I have been specifically in the movement within Kentucky, I have had so many aunts, friends, also my mother-in-law, disclose to me what happened to them because of the work that I do, which can be difficult for me because these are my friends, these are my family members. But the rate in which it happens and the rate in which folks don't often disclose when it happens, it's just really alarming. I think no matter who you are, the more you talk to folks, and they may disclose. And we find in Kentucky as well that substances can be used during the facilitation of the assault. And so if an individual then becomes dependent on a substance because they're often being victimized through drug facilitated assault, that then comes another piece on top of someone who's already being victimized by sexual trauma. Now there's a substance use and misuse element in there. There's an addiction, a codependency that's occurred. And so many cases and so many patients have just a very layered history of the trauma and then the ailments and the conditions that the effects after the trauma. We see this in cases of trafficking as well in Kentucky, where patients will become dependent on substances. And so they may not have the best emergency department reception, if we're being totally honest. Someone may come in, maybe clear, it's been clear that they've been using or misusing, but the healthcare professional not realize that's not of their choice. They don't want to be using. It is an aspect of the sexual assault and that trauma they're experiencing. And then some women willingly use substances to cope after sexual violence. So we all cope, right? Are we using healthy coping skills? Are we using unhealthy coping skills? Did we learn healthy choices growing up? Did we learn unhealthy choices? What was mirrored for us? I know I've spent years curbing my sugar addiction, and I haven't had any gushers, which are a gummy candy, in almost a year because I have a history of diabetes in my family. And while it may not just be my weight that I'm concerned about, it's not healthy to eat a box of gushers in one sitting. It's not a healthy coping skill to use because I'm stressed. So again, while it may be socially acceptable for most people to eat 10 packs of Gushers in 24 hours, that's more socially acceptable than using opioids. That doesn't mean that it's not bad for my body. It is bad for my body. And I know that it's bad for my body. So again, I think we need sometimes just to pause and ask, everyone's going to cope. How are we going to cope? And at that moment, is it the best choice that we can make? And really, who do we have to support us and to talk through that? And then ongoing use as well can be a trauma response, as we know. So pain, withdrawal, all of that's going to compound the trauma symptoms. So we hear from a lot of survivors who use substances that have a history is that it's something they can control. They can control their substance use. If they want to use, it's their choice. If they don't, it's their choice. How much they use, who they use with, what they use. It's a choice. And so what we really hear there is that underlying sense of empowerment. Sexual violence is about power and control more than it is about sexual gratification. So we know that survivors that are impacted by it, they want to have choice. They want to be able to make decisions and not feel like things were forced on them the way they had been in the past. And so I've talked with quite a few survivors who said it's something that I can control. And that makes me feel like I have some kind type of power because I can control that. And I thought that was really interesting, a really interesting lens that they provided. The survivors in Kentucky with prior sexual trauma and PTSD have an increased risk to misuse opioids. So as I was speaking before about individuals who had, come forward maybe later in life, we do see a lot of older females in Kentucky who misuse opioids for pain that is chronic, that can come from that underlying trauma. When your body is just in a constant state of stress, nerves are working overtime, and we know chronic pain is one of the number one reasons that folks cite using opioids, especially like recreationally. And then kind of in the same intersection, but just slightly on down the road a little bit, we have to also mention in our state the specific population of women who are incarcerated or have been incarcerated. So Kentucky has a remarkably high rate of incarceration, one of the top rates in the country of, for our population. And we know that overall incarceration is a negative health effect on someone, right? We know it's very hard to physically and mentally thrive in just that type of environment. It's safety over everything else, right? So you're not getting your vitamins, you're not, necessarily getting all your exercise, you're not getting your sunlight, you're not getting necessarily maybe the best diet, right? So we know that has negative health effects. But in our state, where we have 1/3 of our incarcerated folks self-reporting that they've experienced sexual trauma at some point in their life. We also know there's a high history, a high rate of other types of interpersonal violence, physical, child abuse, child sexual abuse, neglect. We have a lot of hurt people that are already going into our detention facilities in our state when they're arrested. And in knowing that, also understanding the chances of them improving their health outcomes while they're inside is pretty much at zero, not always, but mostly. We have to understand the majority of these women, especially, they're going to be releasing into our communities. Only 5% are going to be locked up for the rest of their lives. So if we have folks that have experienced trauma, and we have these women going into these facilities, and then when they're coming out of these facilities, we need to even look at it as a more pressing health issue. Yet we know they may not be as likely to make primary care appointments. They may not be as likely to complete follow-up care, or they may not have the ability or the means to kind of change up their lifestyles to insert more healthy choices. So just looking at women overall in Kentucky who use opioids and have been affected by sexual violence, when we know so many of them have been incarcerated or have a history of nonviolent incarceration, it really kind of makes us think, like, do we want a healthy Kentucky? We say we want a healthy Kentucky, and we know the less patients, the less overworked, that you all would be, the healthier folks would be, and they would not have to seek, as much medical care. However, we kind of already know the makeup of these women, what they've experienced, and we're not really changing our patterns of care when they're either in incarceration or when they're releasing from incarceration. There's no physical or a mental well-being check for when you release detention. in our communities. And so it's just, again, it's something to think about how over the course of time, when you interact with patients that have experienced sexual violence and opioid use, have they been incarcerated? And if they have, then we kind of know, well, they may have other conditions, other ailments, they may need additional support. And then in Kentucky, what we have found from a 2022 UK study, I want to just give a quick pause to shout out the University of Kentucky over the last, say, 4 to 5 years. So much of the work around opioid use, substance use disorder, and those statistics, especially for us working in sexual violence, have come out of the 2022 UK study. And then also a shout out to my former colleague, Amy Turner, for the amazing work that she did for the last 3 years through our Access Healing Project to focus on the intersection of sexual violence and substance use disorder. But we have in our state, we have 40% of women and nearly 30% of men who enter SUD treatment report that they were sexually assaulted in the last 6 months. And so again, that's self-reporting. And really, if you look at these statistics, you can see there's a higher rate of disclosure among folks that are experiencing substance use disorder, have a history of SUD, when they disclose sexual assault. So when we have our programs and our advocates are in recovery programs, when they're working with maybe detention centers, where they're working in the community with their just survivor groups, they find that folks, and especially women that have experienced SUD and sexual violence, are more likely to disclose to them. And within the last 12 months is significant. That's just within a year. And so knowing 40% of women have experienced that, 30% of women entering treatment have reported sexual assault in their lifetime. It really is an opportunity to say, hey, we have this population, this group, this huge group of women who we know have a history of opioid use or active opioid use. What about sexual violence, other types of violence? Have they been affected? And it's a unique opportunity to offer those intersectional type services when you're already engaging with the patient in a different way. So if they are being open and honest with you about their substance use, then they are more likely to be open and honest about their history of victimization, because it can help them understand some of these chronic conditions. It can help validate for them some of this chronic pain, anxiety, and these types of issues that they have, that they've either been told is because of this, or they just believe is because of a family history and not necessarily that history of trauma. And then what about when someone does disclose to you? And so one of the things, and if we were kind of doing this in person, and if we were kind of chatting, one of the very first things I would kind of start with is a reflection. And I would ask you all to take a moment to reflect. So what if today, a patient that you're working with, what if they disclose to you that they were sexually assaulted 20 years ago? And that's really kind of all they say. This happened to me 20 years ago. Maybe they want to know what their options are to report it, legally. Maybe they want to know what support is out there. Maybe they just want to know what you think as their primary care physician, or as someone who they respect because of your knowledge and your, skill level. What do you think about that? If we don't really talk about this often, especially if we don't engage with patients with a history of sexual violence that disclose often, we can sometimes feel like a deer in headlights, and no one should know everything. And oftentimes we don't talk about, sexual violence enough. And so just to reflect, what would your answer be? How would that narrative, your elevator pitch, so to speak, what would that look like? Okay, say then they told you it happened 20 days ago. What would your reaction be? What would your elevator pitch look like? And then if they told you it was a week ago, what are their options? So just keeping in mind that when a patient does disclose sexual violence, unfortunately, there's not a one size fits all. There's no just here's the script, stick to it, and it'll work every time. And that's often one of the complaints, one of the main complaints that patients, survivors report when engaging with the healthcare system. Like I disclosed, to my physician, and they didn't know what to do because they couldn't do a forensic exam. Well, there's more options than just a forensic exam. So again, how comfortable is that provider? And not even so much as how knowledgeable as it is, do you know that there's support out there for you and for the patient? And that's, again, one of the main takeaways from today is our sexual violence resource centers. They can come in, talk to patients, talk to victims, talk to you all, and go over what the choices are and to make sure that empowerment is being included. And so that a patient survivor feels like, you know what, it happened a week ago. Maybe go get STI treatment, go get some testing done. That may be best. Do I want to? Do I want to take this medicine? And just being willing and able to talk through that patiently and with compassion and validation that what they're going through is real and that it's difficult. We're not the investigators. You all aren't the investigators. We don't have the burden of proof to prove anything to anyone, to just be able to say, I support you and I'm here for you. And then checking in and to inform the patient before you were to call anyone else to assist with their care. So maybe you, at your network, you do have a sexual assault nurse examiner, and maybe you just want to call and consult. You're not meaning any harm, but even if it's not a HIPAA violation, it's empowering to say to the patient, I have a colleague that has more experience with this, or I have a colleague that works with folks that are affected by this often. So let me give them a call. And just again, that's just keeping the patient involved in that care. And then checking to see if your facility or your network has a peer support specialist on staff. Maybe that peer support specialist or maybe your social worker is the best person to speak with patients about sexual assault. It's not saying that you're bowing out. No, it's saying if at your network or if at your facility, that may be the best response, that is the most caring towards the patient. Well, then wonderful, because that means you also have support within your network. And then working to avoid language that suggests the sexual abuse was due to substance use or abuse. Folks that work with patients and opioid, misuse and abuse, you're probably familiar with other types of substances that again, folks can just make really bad choices, for lack of a better way to put it, because of kind of the reaction that the substance produces. And so whatever, that patient survivor discloses to you about the sexual abuse, we should never assume, well, it's because they were wanting to use. This individual had what they had some pills. They went over there. They knew that what they had to do to get the pills. We should never assume those types of things because, again, as we've, already discussed, so many of these cases are layered with other types of victimization, types of history of trauma. We don't really know what folks, were thinking or why they're telling maybe one piece of what happened, but not another piece. So avoiding language that can suggest that they were at fault, it's just going to cause them to be more open and willing to speak with you about their care. And then efficient, this is one of our last pieces here. I know this often comes up. This is something that I provide a lot of consultation on with healthcare providers, and that's what efficient screening and especially primary and urgent care settings look like. And one of the things I had mentioned to Marilyn back a few months ago when we were discussing this was the example of my family care nurse. So I've known her for a very long time. And she knows me, she knows my family, she kind of knows my background. And one day I joked, although it really wasn't a joke. And, she took it serious. We all took it as serious as we should. The way that she asked if I was feeling threatened at home or if I was, feeling safe at home was very off the cuff. As if I were to say, actually, I'm not feeling safe, she might have just dropped her pen and said, really? And that's not the reaction, right, that we want folks to have when we do have patients disclosing a history of violence or that they don't feel safe or something has occurred. We don't want it to feel like, oh, well, if I mention something, it's going to be an inconvenience. Like, oh, if I mention it now, they're going to have to write it all down. I'm not going to know what all they're going to chart about me or what they're going to put. So understanding that efficient screening in your primary and urgent care settings is important just because too, sexual violence is so underreported. So when disclosures do come, they can often come late, especially, from children. And survivors can have a hard time believing they're going to be, believed in any setting that they disclose in. So especially if when you think about, patients that you have a long-standing, history with, and you think, oh, well, they would tell me anything that was going on. We have to remember still the public stigma around sexual violence and how friendly is the messaging at your office or in your network. So many folks and professionals, really all of us, in any type of work that interact with survivors of sexual violence, we expect them to come to us. So if you're assaulted, you can go to the emergency room and get a safe kit done. You can go to the doctor. You can go call the Rape Crisis Center hotline. You can go get counseling. You can go file a police report. When someone's been hurt, when someone's experiencing trauma and they're scared and they're interacting with systems that they never have or in a way that they never have, we're putting a lot of expectations on them to do a lot of things. So while we absolutely cannot force and would not force anyone to disclose to us, how welcoming is our messaging? How quickly do we ask if you feel safe? So when we look at screening, it does matter. Your office environments, they matter. Having the ability to reach for a brochure from my local rape crisis center instead of having to go up in the front desk where it echoes like the Grand Canyon for me to ask you for a brochure about help for sexual violence is not going to get folks to disclose and to reach out for help and to tell you the truth about how they're being affected. And so the same, and we see that also with opioid use. We know that folks using substances or misusing substances, illegally using opioids, they're not going to just come out and tell us a lot of times unless something else is going on. So we definitely don't need to make it any harder. We don't need to have the expectation that they can come to us. How can we reach them better? How can we put signs maybe in our restrooms that have local numbers on them? Again, having them in every room instead of just at the front desk. There's all types of ways that KSAP and our programs can work with agencies to kind of say, hey, let's make this space a little more trauma informed. And again, when it doesn't always matter how long you've known the patient or their family or their history, you've got to take it seriously and sensitively. And I've got a few quotes down here at the bottom because, again, it can be difficult in these situations when you don't feel like maybe you're the best person to do it. But either way, at the end of the day, you're always a compassionate, kind human, right? You can always be that. And that is more helpful than you probably realize. And letting patient survivors know that sometimes difficult experiences affect your health. So is it okay if I ask a few questions about your history? And them understanding it's not out of true nosiness. It's because this can lead to that, and I really need to know if there is a bridge there. And then I see that you didn't express any concerns about not feeling safe at home or at school or at work, but I just like to verbally check in as well, because we may not like to write things down because we don't know how they're going to be recorded. And so offering that verbal option as well. And then would you be comfortable talking to anyone else besides me? about any concerns you have. Maybe you all do have a peer specialist, social worker, or someone else that you just feel in your office is best prepared to handle those disclosures. That doesn't make it, again, doesn't mean you're bowing out. It just means that you're making the best trauma-informed choice that you can at your agency. And this last page, your resources and referrals. Your local sexual violence resource center is an invaluable resource. Again, you're only going to be talking and dealing with folks that are working right there in your communities with your patients. And you can use the interactive map on KSAP's website to find that contact information. Having brochures on hand to display, adding posters and signage, waiting areas, behind doors, restrooms, elevators, by any common areas like the snack machine where it doesn't look like I'm looking at a sexual violence poster. I could be looking at anything at the snacks. And then consulting with your local SVRC staff for their materials, tips, language suggestions, and trainings. And remembering that 24/7 support hotline. Again, patients can call that if you all have a burning question outside of office hours, because you all work odd hours too. You can use that number. SVRCs are knowledgeable on wraparound services. So while you may not know, you can say, I know some folks that might. And in addition to substance use, SVRCs also work with victims with a history of sex trafficking and incarceration. So again, it's not just if you've been sexually assaulted, it's that's primarily, but also what other types of victimization are there as well. And then these are additional links just for you all to have a pro guide for any professional in the Commonwealth. Kentucky Hospital Association Sexual Assault Response website is phenomenal. So shout out to Deb Campbell for getting that. It's great, and it's a great one-stop shop. And then the Child Advocacy Centers of Kentucky, their child sexual abuse medical protocol. Just in case you want to read something that is helpful and interesting, and you were to interact with youth minor patients with a history of sexual violence.